So as an overview, first I'd like as an overview of just the topics we'll cover today. First will be a sort of background and an introduction, some of the epidemiology and some of the statistics associated with pancreatic cancer. And then sort of a key section is understanding the biology and the anatomy of pancreatic cancer. And again, how it is so insidious, how it's so stubborn. The section will be clinical features, how the disease presents, how it's detected, some diagnostic modalities, how clinicians make the diagnosis, and the present state of biomarkers, which, as we'll see, are very key, but it's an area that needs much more research. The fourth section will be therapeutic options, present therapeutic options, and some potentially very exciting future directions that therapy will be going in. And finally, as Ying mentioned, we'll talk about some products for pancreatic cancer research by GeneTex, and this is a subset of products in the larger focus of tumor marker related reagents that GeneTex is working on now. So to start off with the introduction, pancreatic cancer is the 11th most common cancer in the world and is the 7th ranked cause of global cancer deaths in industrialized countries. Using numbers from the year 2018, 460,000 new cases of pancreatic cancer with more than 430,000 deaths. Now, the vast majority of these cases are sporadic, but there is, in 5 to 10% cases, a familial basis for this. Incidence and mortality increase with age. As we'll see, it's a malignancy primarily of older people, with slightly more men affected than women. In addition, risk factors include cigarette smoking, tobacco, diabetes, obesity, dietary factors, alcohol abuse, family history, as we mentioned, Helicobacter pylori infection, and chronic pancreatitis. With diabetes, the average survival at 1 year is only 24% and only 9% at 5 years. To put this in some sort of context, the 5-year overall survival was 2.5% from data between 40 and 50 years ago. So we've gone from 2.5% to 9%, which is something, but it's still not much of an improvement. And perhaps most chilling of all, the incidence of this cancer projected seems to be increasing. So to get some idea, again, from data from 2018 of incidence rates, what you'll notice is that which regions of the particularly affected by it, and specifically certain countries in Europe are particularly have a high incidence of pancreatic cancer, whereas you'll see that of Africa, some of the Middle East, India, and some of Asia are largely spared from it comparatively. When we then look, but instead of talking about incidence, we talk about deaths, we see that the maps are almost superimposable. And so the fact that the mortality parallels the incidence really highlights the lethality and how lethal pancreatic cancer is. And as I mentioned earlier, greater than 90% of deaths in those greater than 55 years old. The single risk factor that seems to be most consistently supported for cancer was, as I mentioned before, tobacco smoking. Smoking seems to be, the trends in prevalence of tobacco smoking seem to be directly related to trends in pancreatic cancer mortality. So stop smoking. Other factors, alcohol abuse, potentially dietary saturated fat, and decreased physical activity. As I mentioned earlier, with the projections of incidence from 2018 to 2004, you'll see that overall, if you look at incidence and you look at projected mortality, you'll see that the graphs are almost superimposable and show, in many cases, sometimes a very gentle, but otherwise a more distinct increase from present time into the next 2 decades. Now, what are the reasons for this increase? as I mentioned, probably tobacco smoking primarily, but also dietary habits, obesity. The slight increase as projected may reflect differences in diagnostic modalities between developed and underdeveloped countries, and also potentially socioeconomic disparities. So before we actually delve into our specific topic today, let's look at an overall classification of pancreatic neoplasms. And so if you look at the left part of your slide, this sort of fractionates and sort of categorizes the different forms of pancreatic neoplasms here. So as we'll talk about, is ductal adenocarcinoma is about 80% of cases. Now, other subtypes and so what this is referring to are cancers that rise from ductal cells of the exocrine pancreas. There's other subtypes of ductal carcinoma that are not adenocarcinoma. One is adenosquamous, 2 is mucinous, 3 is signet ring cell, and 4 is medullary. The reason I actually mentioned these are very rare compared to the full adenocarcinoma. But there was a very recent paper that just came out about treatment for adenosquamous carcinoma, which really shows the necessity of research and how each type and subtype of pancreatic cancer needs to be targeted with research. They did a huge amount of research, chromatin interrogation, other genomic studies to identify the specific mutations in a cancer that is extremely rare by comparison. So the 80% of ductal adenocarcinoma are what's known as cystic neoplasms in about 10 to 15% of cases of pancreatic neoplasms. They can be broken down into different types. These can be of varying levels of malignancy, but they do and are generally treated surgically. As I mentioned, ductal adenocarcinoma, the cell of origin is the ducts, but there are also some carcinomas that actually start in the acinar cells, which are actually the ones that make the digestive enzymes. So in yellow here. There's also an interesting group of tumors called islet cell neoplasms, in about 2% of tumors. And these can be insulinomas, gastrinomas, or glucagonomas, somatostenomas, or VIPomas. And those are derived from the islets, some cells in the islets of Langerhans, which make the key metabolic hormones like insulin, glucagon, somatostatin. About 50% are actually functional, actually put out, and so they cause the related. And then finally, in a very rare set of circumstances, a pancreatic neoplasm can actually be a metastatic site for other primary cancers like renal cell, bladder, small cell carcinoma, sarcoma, or melanoma. Now, for today's purpose, given the vast majority of tumors that will be diagnosed are ductal adenocarcinomas, which are pancreatic ductal adenocarcinomas, which is what we'll be discussing today. Stages of pancreatic cancer, we need to just sort of understand what each stage means. And so if we look at the left side of the slide, what you'll see is with stage 1, there's been no spread, and we'll see some diagrams of this later. So there's no spread, or it's considered resectable, means surgery is a valid treatment approach. 1A, in stage 1A, it's limited to the pancreas. The primary tumor is less than 2 centimeters in size. If it's between 2 and 4 centimeters in size, but less than 4, it's limited to, it's called 1B. In stage 1 is limited to the pancreas. Stage 2, there's localized spread, and so it's considered borderline resectable. This is when the tumor gets greater than 4 centimeters in size and is either limited to the pancreas or, as we'll see later, can spread to local lymph nodes. Stage 3, there's been more. So surgery really is no longer an option. It's extended to local blood vessels or nerves, but there's been no distant spread. And of course, stage 4 is metastatic. It's spread to distant sites. If you look at the rate, again, we'll just focus on this left side here of the exocrine pancreatic cancer. You'll see that 1A has about 14% 5-year survival, and it gets progressively more dismal, and so by stage 4, maybe 1% at best. So to understand, I mentioned earlier, to really understand why this cancer is so problematic and so really understand the anatomy and biology of PDAC. So if we start over here on a little bit about the anatomy. So we'll see the pancreas here, just below the stomach, nestled right at the turn of the duodenum, underneath the liver and the gallbladder. And then to really understand it, you have to understand something about ducts. And so if the liver would be up here, you have the right hepatic duct, which delivers bile, left hepatic duct into the common hepatic duct. This is the gallbladder. It drains through the cystic duct. The cystic duct meets the common hepatic duct and becomes the common bile duct. Then empties through the major duodenal papilla, or the ampulla of Vater, in conjunction with the enzymes secreted, enzymes released by the exergent pancreas through the duodenal papilla here. So it's key to remember this anatomy. The structure of the pancreas. The spleen would be over here on the left, on the far right side of your slide. PDAC tumors are in the head of the pancreas, so it's right nestled up there, right adjacent, right in here, adjacent to the common bile duct. 15% are in the body, 10% are in the tail, about 2% are multifocal. So tumors in the head of the pancreas, so the vast majority of them, present earlier clinically with obstructive jaundice, okay, because it's of obstruction of the common bile duct, and pancreatitis, probably because of backup along the pancreatic duct. Body and tail tumors present later because they don't obstruct anything right away, and they have a worse prognosis because they're detected even later than tumors in the head. And just to give you some idea, because we'll look at a couple of these for cases a little bit later. For those of you who haven't who've never seen a CT scan or are unfamiliar with them, basically the patient here is on their back, their feet are sticking out at you, so the right leg's over. You're looking at the bottom of the right sole here, the left sole here. Here's the right kidney, here's the left kidney, and this is and then here's the spine. And so the pancreas would sit right here like this, right in this area. And then to understand sort of stress in the anatomy here, you can see the pancreas. Here we see local lymph nodes, which are immediately adjacent to the pancreas. In addition, the pancreas is right adjacent to major vasculature, not to mention the duodenum, and then of course the liver. So we can see how it's really surrounded by a lot of anatomy. To understand, now moving from sort of gross to something to more histology, there are probably about at least 3 systems for grading premalignant lesions in PDAC. The one that has been sort of most well documented is the pancreatic intraepithelial neoplasia, PANIN system. A well-described premalignant lesion. And the pink classification is based on the extent of cytologic and architectural atypia. And what's really been known actually for some time is that the progression has been marked by increasing genetic alterations, and we'll see this again. So we have normal epithelium here, the PANIN1, which is low-grade IPMN or intraductal papillary mucus neoplasm. The first thing you really see is activation of KRAS, and we'll talk about this again. Then you see more atypia, other effects, not only in immune cells in the surrounding stroma and the extracellular matrix, the types of cytokines released goes from a low-grade IPMN to a high-grade IPMN. And then to PANIN3, here you have P53 inactivation, SMAD4, and you moves into invasive IPMN, and as we'll see in the next slide, frank carcinoma. So this is sort of just saw, but we're looking at it more histologically. But it really sort of rams home the same sort of themes that we just talked about. And PDAC is histologically demonstrates glandular organization with duct-like structures, and that's what you see here. So PAN-IN1A, you have elongated cells sort of early in the malignancy process. Elongated cells, mucin production. Then you get papillary architecture in 1B, nuclear abnormalities, loss of polarity, PAN-IN2. PAN-IN3, carcinoma in situ. You see increased mitotic figures, and then you have frank carcinoma with invasive growth. And as we'll talk about, this desmoplastic response in the stroma surrounding the tumor. The earliest mutation is this KRAS activation. So the green is sort of an activation or upregulation, whereas red is either loss of free. NK4A changes, then you lose SMAD4, P53 is inactivated, and activation of telomerase. Really, I'm talking now about the molecular biology. What's important about PDAC is the very supportive interactions that occur between the surrounding stroma and even associated host immune cells and the tumor cell. And so basically there's metabolic reprogramming of PDAC cells and interactions with the tumor microenvironment. And so, and basically it just supports the tumor microenvironment, becomes supportive metabolically in terms of reprogramming for the growth of the tumor cell. That would include, it even goes another step in that in addition to actually supplying the tumor cells with key metabolic intermediates to grow, what also happens is there's active engineered by the tumor cells and the tumor microenvironment. And so one of the key players are these cancer-associated fibroblasts, which secrete factors and have actions that not only support the tumor cells metabolically, but serve to, with other involved cells, with other cells, including the extracellular matrix and even suppressive myeloid cells, turn off the immune response against pancreatic cancers. And so PDAC, and this is probably a thing that you should remember, is it is characterized by a desmoplastic stroma and an immunosuppressive TME. The other thing of importance is that PDAC tumors are generally very heterogeneous, both molecularly and cellularly, which is a major factor in why they're so resistant to so many different kinds of treatments. So now I know a little bit about the biology, some general themes about the molecular biology, a little about the clinical features of PDAC. How does this cancer present, and how is the diagnosis made? So really, the first thing is a patient comes in complaining of certain symptoms. And so the prevalence of pancreatic cancer symptoms can be broken down in tumors, as we saw earlier, in the head of the pancreas, where the vast majority of tumors are, or in the body and tail of the pancreas. So let's look at these first. So the top three are weight loss, jaundice, or basically turn yellow, and pain, abdominal pain. You can also see loss of appetite, dark urine, light stool, all because of disruption of the biliary system, or loss of pancreatic function, as well as vomiting and weakness. Compare that to the body and tail of the pancreas. Remember, these generally present later. And the reason is there's no jaundice. Jaundice is down here. But you still see weight, pain, and nausea as the top three symptoms, and weakness. Other signs and symptoms can be hypercoagulability, which can be seen in other cancers, pruritus or itchiness from bile salts in the skin, again, because of that the bile duct, palpable gallbladder, and recent onset diabetes. The initial workup involves basically history and physical examination first, labs including liver function tests, direct and total serum bilirubin, amylase and lipase, and then, as we'll talk about, CA-9 and CEA or carcinoembryonic antigen. And then probably one of the key modalities is imaging. We'll discuss that. So sort of as a general theme to come away from this slide, the diagnostic process for PDAC relies on clinical suspicion, from the history and physical, imaging modalities, brush cytology or fine needle aspirates for pathological confirmation, and then tumor marker measurement. So what diagnostic modalities are used to detect PDAC, and which specifically imaging? And really the slide, but let's focus on the multi-phase helical computed tomography is probably one of the most commonly used. The other one is endoscopic ultrasonography guided fine needle aspiration, so EUS. One of the back in the day, one of the ones that was commonly used was endoscopic retrograde cholangiopancreatography, or ERCP, but that's not used as much anymore. The nice thing about EUS and at the time ERCP was that you could actually pass a guide wire and actually get samples. So the EUS and the ERCP would allow you to get actual tissue samples of the tumor from the initial probing done with these techniques. This, of course, would just be visualization. Examples of CTs here of two different presentations. Remember the same orientation. Here's the patient's spine. The patient's lying on their back. The right foot sticking out here. The left foot sticking out here. And so what you're seeing, and left kidney, right kidney. And what you see, here's a 58-year-old man. Again, remember what we talked about. A 58-year-old man with vague abdominal pain and jaundice. And what you see here is a large tumor right in the head of the pancreas. So that would be blocking the common bile duct, and that would lead to the jaundice. Over woman with vague abdominal pain and a palpable mass. I mean, you can feel this. And what you're seeing, this is all tumor. Because this is actually in the tail of the pancreas. This is her abdominal, probably her abdominal wall here, her upper abdominal wall. And this was actually, the physician could actually palpate this. And so again, no jaundice, but just some abdominal pain and a mass that could be felt. So this tumor is actually in the tail of the pancreas. This one was in the head. So we've discussed a little bit about how it presents, some of the imaging modalities that are commonly used. Let's talk now about some of the biomarkers related to PDAC. And so the main one I think this audience is aware of is carbohydrate antigen 19-9, or CA19-9. It's actually the only FDA-approved prognostic marker for PDAC at the present time. We'll see that there are a lot of others sort of in the works. CA19-9 is the main one at this point for clinical purpose. It's expressed on cells of the pancreaticobiliary system, and it's detected by monoclonal antibody 19-9. It's dependent on the Lewis blood group. Thus, what that means is that the population do not express CA19-9. It may show upregulation as much as 2 years, prior to PDAC diagnosis. Levels correlate with tumor size, tumor stage, and tumor burden. However, it's not the most specific. There are false positives in cholangitis, pancreatitis, obstructive jaundice, and other cancers, not just pancreatic, including gastric or colorectal. And hepatic and pancreatic cysts can interfere with the values. Main value of CA19-9. It's really valuable to follow therapy and detect any recurrence. And with pancreatic cancer, it's generally always coming back. The recurrence is 66 to 92% in the first 2 years, even after hopeful curative surgery or adjuvant chemotherapy. There's studies that shown that it's not recommended for screening the general population. Some recent papers, particularly from one and two, that are looking at other biomarkers that could be used in conjunction with CA19-9 to distinguish PDAC from benign disease and no disease, or i.e. healthy patients. And thrombospondin 2, as I said, a couple of papers to come very recently, is an extracellular matrix glycoprotein which mediates cell adhesion. And maybe in conjunction with CA19-9, it may be a better detector for PDAC. There's even been some papers, perhaps a little older, that carcinoembryonic antigen, or CEA, predictor of advanced PDAC in CA-19-9. But really the thing to come away with from this is at this point it's CA19-9. But a great deal of research going on because in terms of looking at other biomarkers. One that's also been written up is glypican-1 expressing circulating exosomes. So actually detecting glypican-1 in exosomes as a way to, looking at using it for prognosis, and that GPC1 overexpression is associated with a poor overall survival. What's also been kind of interesting is that there seem to be certain microRNAs and long non-RNAs, as well as circulating tumor DNA that could be used as potential biomarkers. But again, these are still basically from the lab, and if anything, in extremely early phase trials. Over in depth, some of the predictive biohumoral markers and histopathologic and molecular characteristics, in addition to some sort of prognostic histopathologic and molecular characteristics, as well as prognostic biohumoral markers. And so predictive really gives info pertaining to the effect of a therapeutic intervention. Prognostic generally gives info related to overall patient outcome regardless of therapy. And again, we see CA19-9, some inflammatory biomarkers, the cytokines, glypican-1, as we mentioned, various microRNAs and long non-coding RNAs, some circulating tumor DNA, and circulating tumor cells. And then in terms of, as we'll see with certain targeted therapies, knowing the BRCA1, BRCA2 status, and also the HENT1 status, which is actually a transporter for one of the key therapies, gemcitabine, as well as the hypoxia status, and as we mentioned, microRNAs and certain translocations. These are all things that are undergoing intense research at this time. So then we can now move on to sort of what are the therapeutic options for PDAC. We've hopefully given you some idea of why the tumor can get so bad so quickly, both on the molecular, cellular, and anatomical base. But to put that in some sort of framework, let's revisit our stages. And as I mentioned earlier, we're actually seeing some pictures of what each of the stages would represent. So remember, we stage 1 is considered resectable. So stage 1A means the cancer is smaller than 2 centimeters. Stage 1B means the cancer is larger than 2 centimeters, but generally less than 4. But in both cases, it's still sitting there contained in the pancreas. Okay, so this would be considered resectable. Stage 2A means that the cancer is larger than 4 centimeters and has started to grow outside the pancreas, but has not spread to those lymph nodes. And stage 2B means the cancer has spread to nearby lymph nodes. And so here it's actually starting to invade, or remember those local lymph nodes that were grouped all around the pancreas. By stage B, it has actually spread to those. So, and that would probably be stage 2, would probably be considered borderline resectable. That has to be a clinical. Surgery is elected for a cancer in the head of the pancreas. The procedure is called a Whipple procedure. It is a gargantuan surgery. If you hear, so once here's the stomach, there's the pancreas underneath, there's the tumor in the head of the pancreas, here's the duodenum, here's the jejunum, so small intestine, gallbladder, the common bile duct, and then of course the hepatic ducts. This area, this color, are all the regions that are excised and removed, and surgically removed in a Whipple procedure. So basically involves removal of the head, the uncinate process of the pancreas, all of the duodenum, approximately 15 centimeters of jejunum, the gallbladder, the bile duct, the distal, and then you reconnect everything that's been removed back to what's left of the jejunum. So this is the remnant of the pancreas minus its head. It's now been fused back into the jejunum. The common hepatic duct here is now fused into the jejunum, and the stomach is also fused into the jejunum. So it's a huge surgery, but it's only really applicable in 15 to 20% of cases. For tumors that are in, remember, the body or the tail of the pancreas, generally what's done is called pancreatectomy and a splenectomy, and it's actually in about half the number of cases. It's actually resectable disease. Our surgery, and so we saw this. This was on like the first slide of the presentation. So here's actually here's an actual surgical specimen that could come out from a Whipple procedure. So just to orient you again, here's the head of the pancreas. This is all tumor mixed in here. Here, pancreatic duct, and the rest of the pancreas would be out here, but that's still in the patient. Here's the biliary duct. Here's the mark of where the resection for the common bile duct. Here's that resection margin, and here's the exit point for both the biliary duct and the pancreatic duct in the duodenum. And then this sort of folded tissue here is duodenum. So resectable disease, basically it's surgery with neoadjuvant or adjuvant cytotoxic chemotherapy. And it can also be combined with radiotherapy, which previously was used for pain control, but it can also be used for locally advanced disease. The state-of-the-art adjuvant cytotoxic chemotherapy regimen is M-FOLFIRINOX. So it's made up of 4 drugs: modified 5-fluorouracil, leucovorin, irinotecan, and oxaliplatin. The problem with M-FOLFIRINOX is it's extremely toxic. Patients, and again, we'll talk about this a little bit later. The option for patients who are less robust or resilient is gemcitabine and capecitabine. And this is sort of one of the classic other regimens, but there are others, and usually always gemcitabine based. However, even with this, the longest overall survival is at best 54 months. As we look at, in this case, the cancer has spread into blood vessels near the pancreas. It's actually invasive, so it's no longer surgical. And at stage 4, the cancer is spread to other parts of the body. And as we'll see, the most common place it likes to go is the liver. So in current treatments for pancreatic ductal adenocarcinoma, this would be in all cases. We talked about resectable tumor, stages 1, perhaps stage 2, where pancreatic section and adjuvant chemotherapy. And then for cases that are borderline, I guess that would be more stage 2. You either, for non-resectable borderline and or non-resectable locally advanced tumor, so the ECOG score, the Eastern Cooperative Oncology Group. And basically that's a measure of functional status. And so understand this, the score of 0 means the patient's completely asymptomatic, fine, showing no signs of having disease. But it gets progressively worse to 5. 5, you're dead. And so stage 1 is symptomatic, but you can still walk around, do light work. Stage 2 or ECOG score of 2 is symptomatic, and you're in bed, but you're in bed less than half the time. You can still do some things, but for the most part, you're fatigued, weak, and you're in bed less than half of the day. By ECOG 3, you're in bed more than 50% of the day. You can still get up, but you're in bed most of the day. And by 4, you're bedbound. It goes into deciding the functional status of the patient about how aggressive you're going to go. So, or an ECOG score of 0 to 1, so, actually doing pretty well. There's neoadjuvant radiotherapy or chemotherapy, and the chemotherapy is generally FOLFIRINOX. There's second-line treatment, but as you can see, even with a resectable tumor in resection, you're getting a median survival time of 26 months. Here, with an ECOG score of 0 or 1, 6 to 18 months with radiotherapy and chemotherapy and aggressive chemotherapy. If the ECOG score is 2, as we talked about, we would think about using gemcitabine. But if the ECOG score is higher than 2, so 3 or 4, then basically you're talking about supportive care. And even then, you're talking the median survival of a little over half a year. And in metastatic tumors, so this clearly would be 4. And the ECOG score, if the functional status is relatively high, you give the more aggressive regimen. If the ECOG score is 2, you give gemcitabine. If the ECOG score is greater than 2, it's best supportive care. So it's pretty grim. I just talked about metastatic sites, just seeing any organ is possible, but most are abdominal. The liver is the most common site of PDAC metastasis, followed by the peritoneum, and then down the road, the lung. The adrenal gland and the bone metastases in about 10% of cases. Metastases from the body tail, or tumor primaries in the body or tail, can bypass the liver to extra abdominal organs. Now, what's interesting, we have to keep in mind here, and again, why this is so insidious, why this cancer is so stubborn, is that actually there's been researchers have found that fibroblasts associated with the primary pancreatic tumor can actually prime the liver to receive metastasis. Remember, in a primary tumor, it shoots off potentially millions of cells all over the body. The metastasis number is actually somewhat more limited than that. So most of the metastatic cells never find home and they die. But it actually formed through IL-6 released from fibroblast cells associated with the tumor, a chain of events that actually makes a nice niche for that metastatic PDAC cell to form a metastasis in the liver. So it's quite diabolical. Common sites of metastasis, as I mentioned, the liver, the portal vein, the superior mesenteric blood vessels, and also the ligament of Treitz is just some of them. So in addition to they are right now, or the state of clinical is fairly vigorous cytotoxic therapy. Well, where are the future directions going? And keep in mind before we get into this that this is for very specific cancers, oftentimes a small minority of cases. So it really is the very definition of personalized cancer care, because information has to actually be derived from samples from the actual patient tumor to potentially approach and design therapies for that tumor. And so in a nice review article in Nature from this year, we talked about where in some areas of intense research that are going on to look at this. And it sort of goes with the acronym PRIME. So pathway inhibitors, repair-based, immunotherapy, metabolism, and extracellular matrix, PRIME. And this is a very complex slide. But what it does is that looking at interrupting status, basically remember we talked about the BRCA status of the tumors, of the tumor cells. We can also attack certain metabolic features of the cancer to improve. I mean, the PDAC tumors do not do well, are not particularly susceptible to immunotherapy, again, due to that immunosuppressive environment fostered by the tumor microenvironment. But there are ways that potentially it could be improved and made more vulnerable. And then also direct pathway inhibition. So these are, again, and then also targeting the extracellular matrix, which also seems to be a key component of this. So these are all being worked out. So in terms of conclusions and future directions, as we saw, there's adjuvant treatment with multi-drug chemotherapy, or FOLFIRINOX, has prolonged survival of patients with resectable PDAC, but only perhaps to 4.5 years maximum. Improvements for patients with advanced disease have been much more limited. We need to identify biomarkers, as we talked about earlier, for response to cytotoxic therapy, targeted therapies, and immunotherapies. And this is actually probably the most crucial thing. We need better preclinical models of PDAC biology to even assess the potential effectiveness of new therapies. And that will involve more extensive, comprehensive genomic profiling to better apply precision medicine to PDAC therapy. And also, this is really the key, but the development of therapies targeting activated KRAS. I didn't talk about this much. As we mentioned, and as we saw on those two slides, activated KRAS is really the key. It's mutated in probably 80 to 90% of PDAC cancers. But the problem is, and many of you may probably know this, RAS proteins are eminently undruggable. They are extremely difficult to attack the active site because they have such high affinities for GTP and GDP. So it's proven to be very, very difficult. People are trying again. For a while, people had given up on RAS. It was discovered many decades ago. Then they sort of gave up on it because nothing seemed to work. But now they're revisiting it. So there could be some hope there. So I would just like to wrap up with an overview of GeneTx's pancreatic cancer product catalog. And again, as Yiying mentioned, this is just a part of our of GeneTx's catalog for tumor markers and biomarkers. And it's an area that the company is continuing to pursue. So let's just look at a few of the products that are relevant. First, remember glypican-1 was expressed on it's a glycoprotein attached to the cell membrane. Expression is upregulated in many diseases, including pancreatic cancer. There's ongoing research into the potential clinical utility of assessing enriched glypican-1 expression on circulating exosomes as an early cancer marker. So this is a very nice rabbit polyclonal antibody that's been validated for multiple applications. Several validated for flow, works very for Western blot, looking at both the glycosylation status and also for IHCP. So here is normal pancreas, which is largely unstained, and then robust staining in pancreatic cancer. So this is a nice antibody. Gene mutation. This is also a very exciting antibody. As I mentioned, KRAS is mutated in nearly all pancreatic ductal adenocarcinomas. So usually it's greater than 80 to 90%. And interesting is the KRAS G12D is the most common mutation seen. But so G12D and G12V mutations represent about 3/4 of the mutations in KRAS. Particularly this rabbit monoclonal, validated for 3 applications and in a couple of species, is very specific using these pancreatic cell lines for the G12D mutations in rats. In addition, look at pancreatic cancer tissue, one with the wild type KRAS and one with the G12D, you can see clearly the G12D mutation tissue is recognized. And of course, sort of the pancreatic cancer detection biomarker is carbohydrate antigen 19-9. So CA19-9 refers to the Sial-Lewis A, tetrasaccharide antigen, useful for the diagnosis, monitoring therapy, and detecting recurrence. So as I said, this antibody is commonly used. Again, available in for multiple applications. It's a mouse monoclonal, validated for flow. Interestingly, if you look at ICCIF, here is a low CA19-9 expressing cell line. I'm sorry, a high expressing. So you can see a very distinct signal in comparison to a low expressor where you don't see a signal. What's also nice about this in comparison to another commonly used reagent on the market is that it's very specific to CA19-9 or Sial-Lewis A. This is a glycan array. So you can see that it only picks up the Sial-Lewis A, or basically the CA19-9 motif. This other 19-9 antibody detects both CA19-9 and Sial-Lewis X. But this one, the GeneTx one, is much more specific for the CA19-9 marking. If you compare the same 2 antibodies, the GeneTx antibody and the other antibody on Western blot, you can see it's much more robust. It also gives a much better and much more robust signal on pancreatic and PDAC tissue at twice the dilution. So And also mentioned earlier, thrombospondin 2 is a secreted protein that can be expressed together with CA19-9 in patients with early PDAC. So here's a conditioned media sample and also very robust staining on pancreatic cancer. So we'll see where the research goes from there. And other relevant antibodies, again, this is just a subset of what's available. C-peptide antibodies, M4 antibody, P53, PDX1, and pancreatic polypeptide antibodies. And I would like to thank you for much appreciated. Europe
Thank you very much, Alex, for this informative presentation.